The topic for discussion which is going to start now is why NIV fails. And all of you here who are using non-invasive ventilation to a large extent would really realize this, that failure of NIV is actually a sword which kills you from both sides. One, you have lost the pride of success because you know the success of NIV brings a lot of benefits and advantages along with it. Second, you are doomed, because the failure carries high mortality in your patients. So both ways, a failure of NIV is something which has a lot of significance in the clinical practice where we use NIV day in, day out in our patients in the intensive care unit. We all remember that we use non-invasive ventilation because we are looking for assisted ventilation without the use of endotracheal tube. But actually, what we forget are some of the basic tenets of NIV, that the foremost and important is that it's not a substitute for mechanical ventilation. We are not substituting mechanical ventilation by using non-invasive ventilation. What it means is that you need to use it to avoid intubation only patients which are likely to be of benefit. So what the bottom line is that you can use it in patients who are likely to benefit. You are not going to use it as a substitute of mechanical ventilation in all patients where a ventilatory assistance demand is there. Also, then it becomes very important that the patient selection is the very important part. A role which is played by a patient selection is very important key to success of non-invasive ventilation. And nevertheless, a failing patient is to be identified prior to a catastrophe, which is usually a cardiopulmonary arrest or a hemodynamic instability, which ultimately leads to very poor outcome of patients who fail on non-invasive ventilation. So what I mean to say here is that it's not a substitute. It is in fact only used as assisted ventilation in group of patients in whom the likelihood of success of NIV is much, much higher or proved in various trials that it is very likely to be effective. You are going to use it. And that's what my talk is going to be centered around. We all understand that when we use non-invasive ventilation and do not intubate these patients, obviously there is less intubation, there is reduced ICU mortality, hospital mortality, and need for therapeutic interventions. But at the end of the day, if you have a pool data of all patients together which have been used with non-invasive ventilation, the mortality benefit at the end of the day is not significant statistically. So keep in mind that it's a heterogeneous group of people in whom the mortality may not ultimately matter. So what it matters is to identify the patients in whom the mortality benefit is there and in whom it is not there. This is a paper by Honrubia, basically, which came in Chest long ago, which showed that one particular group of patients with respiratory failure, that is pneumonia, almost 100% patients went on to intubation and mechanical ventilation. So it identified certain group of patients who are unlikely to benefit from non-invasive ventilation. So what it means to suggest is that right from the beginning, when you start non-invasive ventilation in these group of patients, you know the chances of failure are very, very high. So once the failure is there, the importance of failure is very clear. As I said that this is basically a Massachusetts General Hospital observational study which they released long ago, that the NIV failure is to the tune of about 38.4%, but the difference is that the mortality in the failure group is nearly about 47% versus only 5.4% in the group which has got a success out of use of NIV. So what it means to say is the difference between mortality of NIV success between NIV failure is so huge that you need to do some things before you start the patient and then constantly look for it, that you don't end up with those kind of failures where it is beyond any control of yours to improve anything further. This is another study by Esteban, which was published in New England Journal of Medicine, which showed that if the re-intubation after the patients who have shown extubation failures, you use non-invasive ventilation. But if you delay this non-invasive ventilation to a point beyond where much can be done, it worsens the mortality of the patient. In fact, delaying intubation by 10 hours has been shown to increase the ICU mortality as well as the ventilator time which is required in future for these patients in the intensive care unit. So it also means is that it's not only picking up the NIV failure, but then hanging on to non-invasive ventilation and trying to prolong it as far as possible, and then doing intubation and mechanically ventilating patients makes the prognosis poor, and with every hour passing by, it becomes more poor. So what it means is that if you have identified that this patient is not likely to benefit, is failing on non-invasive ventilation, there is really no point in carrying on with this non-invasive ventilation in those group of patients. What constitutes an NIV failure? Obviously, most of the times, and unfortunately, this should not happen, and that is the cardiopulmonary arrest. This is something which is obvious but should not happen. What you need to do is, you need to have your judgmental presence to see that signs of NIV failure which are coming up in a patient who's put on non-invasive ventilation. And they are like increased work of breathing, progression of underlying disease. That's a very important cause. If your patient is comfortable on non-invasive ventilation but is failing because of the progression of disease, there is nothing short of intubating this patient and putting the patient on invasive mechanical ventilation. And it happens in patients with severe sepsis who develop multi-organ dysfunction. It happens in the patients with coronary artery disease who develop myocardial infarction and require interventions. Also are the worsening gas exchanges, like further fall in pH or further increase in carbon dioxide, or there is a worsening of hypoxia in these patients. But very important is clinical parameters of NIV failure, which are like increase in respiratory rate, patient becoming more drowsy, mentation becoming more poor, and hemodynamic instability, development of hypotension, patient getting drowned in secretions, and of course uncontrolled agitation, which we are not able to control with the sedation which we are allowed and which we are using on our patients on non-invasive ventilation. If patient is very, very agitated, this patient is going to be a failure for non-invasive ventilation. So to picking up these patients of NIV failure, you need to have your clinical parameters, you need to have gas exchange parameters, and of course you need to have the underlying disease in mind to see that these patients are likely to fail, so that we don't pick them up once the cardiopulmonary arrest is there, because that sure shots is going for a mortality in the patient. So once the patient is failing, what we need to do is to identify the cause of failure. And success of non-invasive ventilation is actually dependent on a triad where you need a good patient, a good ventilator, and a good interface. So all three things, you need a ventilator, an interface, and a patient. So if you have three good things, then it should not fail. So if any one of them is a problem, you can have a failure. And this is one of the study which was published in Critical Care Medicine, which tried to analyze the reasons of failure depending upon the various group of diseases like COPD, non-COPD, acute lung injury, ARDS versus cardiogenic pulmonary edema. If you look at it, hypoxia, which is not correctable by non-invasive ventilation, is predominant cause of failure in ARDS. Hypercapnia is a predominant cause which is not correctable in COPD group. Interface can be a troublesome thing in any one of them. Secretions can be there in any one of them. Mentation is a problem in any one of them. And agitation is mostly seen again in ARDS group or COPD group, which is maybe because of hypoxia, maybe because of so many other factors which I'm going to discuss. And very important, progression of disease, which is very important factor of failure in ARDS group, is the one. The patient is in ALI, you start the patient on non-invasive ventilation, but patient progresses to ARDS. Or a patient comes with sepsis with ALI, but goes on to develop ARDS. Progression of disease is a very important factor of failure of NIV in patients who are being given NIV for ARDS, ALI group. And consequently, the failure rate is also very high, which is about 60% in this group in comparison to only 18% in cardiogenic pulmonary edema versus 24% in COPD group, which is about intermediate. So this NIV failure in various studies have ranged from 5 to 40%, and the failures are either early. Early is that you are not able to initiate non-invasive ventilation, and for this most important causes are ventilator asynchrony, which Dr. Khilani is going to take next to me, interface problems, and extreme agitation of the patient. But the late failure occurs in those patients who have been already established on NIV, but further on go on to develop failure. That is like gas exchange abnormalities and progression of disease, or poor mentation or secretions in these patients. Ventilator asynchrony, I'll skip this slide because Dr. Khilani is going to take it in details. But if you have factors which can be corrected like anxiety and claustrophobia or mouth breathing or a machine, then they can all be set right. But of course, lots of times you require a patience as well as some amount of sedation to make the patient more synchronous to breathe with the ventilator spontaneously. These are the various machines you can use. Furthermore, the earlier study of success versus failure, which was published by Suhu in Critical Care Medicine, it is a very short study, only in 12 patients, but it did discover two things: that those patients who are edentulous, chances of failure are high, because the support to the interface is not that good, so these patients are likely to fail. Second thing, if you use nasal ventilation in the patients in the intensive care unit, mouth leaks as large as about 300 ml occurring can be of significance and produce failure. So if the leaks are large or the patient do not have teeth, they heralds almost NIV failure. They also showed that if PCO2 is more than 10 millimeter or increase, or pH is more than 0.05 increase after 1 hour of starting of NIV, that also is actually of a reason for failure. If it doesn't happen, it's a reason for failure. If they achieve the targets, that's the sign of success, basically. The leaks could be one of the major cause of failure. Initially, it can occur. It can lead to ineffective ventilation, eye irritation, noise, and poor triggering, because there is a loss of pressures and the machine doesn't sense anymore and doesn't trigger it. So it becomes a big problem. And the solution is to get a good fit and customized mask, adjustment of the headgear, use chin strips or different kind of interfaces. This is a horrible picture which shows that if you try to block the leaks like this, it doesn't give you any success because triggering is not occurring, and ultimately patients develop more hypoxia and more hypercapnia, goes on for requiring invasive ventilation, or may actually develop a cardiopulmonary arrest. There can be full face masks like this, which can be used, and what you need to do is choose the best fit for a patient, and which may not be true that one size doesn't fit all patients, and even a big face mask may be a very small one for your patient, or even the smallest mask may be a very big mask for the very thin and emaciated patient. Then there is another important factor, that on the basis of these disease conditions, the indications have come where the non-invasive ventilation is recommended and where it is not recommended. And if you look at this chart, it clearly shows that patients with COPD exacerbation, patients who are to be facilitated of extubation, but underlying COPD is there, cardiogenic pulmonary edema, and those patients who are immunocompromised are the group of patients in whom we have a level A evidence to recommend non-invasive ventilation. Rest of all these patients are actually in the group where a lot of care and a lot of monitoring is required if you use non-invasive ventilation in those patients. This is one study which was published in European Journal, which showed that why the patients on non-invasive ventilation with COPD acute exacerbation, which is the most common indication to use NIV, fails. And this study has an exhaustive analysis which was done at the time of admission and after 2 hours of admission and use of NIV. They used parameters like Apache scales, more than or equal to 29 or less than or equal to 29, Glasgow Coma scale of 11, 15 or less than 11, and they also use the respiratory rate criteria of less than 30 or more than 30. And the results of this were so good that they could predict at the time of admission, also at the time of 2 hours of use of NIV, whether these patients are going to fail. So the prediction formula which was calculated, and if you look at the red bars, in fact, they indicate 75 to 100% chance of failure of this patient. So if you have these characteristics, the chances of your failure are almost 100%. So this is the risk of failure. If your patient with COPD and acute exacerbation at admission shows a Glasgow Coma scale of less than 11, Apache of more than or equal to 29, respiratory rate of more than or equal to 30 per minute, and pH of less than 7.25, the risk of failure is about 70%. And if this pH doesn't increase to more than 7.25 after 1 hour, after 2 hours of non-invasive ventilation, the risk of failure rises to 90%. So you need not pull on these patients for further long on non-invasive ventilation. They should be intubated and they should be put on ventilation. In fact, this is the graph in which they have shown that these values are of high discriminatory values in comparison to the line where the test would have been non-discriminatory. It clearly shows at admission and at 2 hours of use of NIV, the discriminatory value of these findings is very, very high. The sensitivity and specificity I have also mentioned, but this is one of the trials which accurately tried to find out what are the predictors of failure in patients who are given NIV or to be given NIV in the group COPD with acute exacerbation, which is most commonly used. This is one another study which showed that lower body weight and pneumonia in patients with predicts NIV failure. In fact, the success group had the average weight of 69 kg and pneumonia only in 9% of cases, while the failure group had the average body weight of 48 kg and pneumonias to the tune of 39%, although the compliance remained the same. The other things like persistent hypercapnia and persistent hypoxia, which is more of a reason of NIV being ineffective rather than a failure, because there are some things which you can do about them. You can change the pressures, you can look up for the leaks, you can see if patient is not rebreathing into the machine, and you can correct the asynchrony. If these are the factors, you can correct and wait for some more time for the patient to be on a NIV. If it is hypoxia, obviously controlled oxygen therapy can be given, and some more time is required, because once the patient is on NIV alone, then the oxygenation do fall. And if you start them with controlled oxygen, it takes some time for the oxygen levels to come to acceptable levels, what you want your patients to have in the intensive care unit. And then one more thing is that the second group of patients who receive non-invasive ventilation are the acute lung injury. And yeah, this is the, okay, fine. So this is just about to finish. In this group, what they found is that if patients of acute hypoxic respiratory failure with acute lung injury, if they have shock, then there is 100% failure of NIV. So there's no need to put these patients on NIV. Similarly, if patients have metabolic acidosis or severe hypoxemia with PaO to FiO2 ratio of less than 1:1:2, chances of failure are very, very high. So these patients should be either not used with NIV or with great caution. This is again another study which shows the same things. Severe patients, ARDS patients, patients with community-acquired pneumonias have got high chances of failure if the NIV is used for acute hypoxic failure. And then what we come down to is ultimately that you have some green zones like COPD and cardiogenic pulmonary edema. You have red zones like ARDS, multi-organ failure and tight UO. And you have some orange zones where you can use it with a lot of caution like asthma, obesity, hyperventilation, upper airway obstruction, early ALI. So just to conclude, that NIV failure we know carries a high mortality. What it needs to do is that you should have a risk stratification before you put the patient on NIV, where sicker patients and patients in the late course of disease are likely to be failure and should not be attempted to put on NIV. Underlying disease like acute lung injury, ARDS, pneumonias have high failure rates, so should be considered for mechanical ventilation from the beginning itself. But once the patient is put on non-invasive ventilation, close monitoring is required with a low threshold for intubation, because the moment you detect NIV, you don't want catastrophe, you want to convert this patient, put on on mechanical ventilation. Technical factors can be always looked into it, but very importantly, it does require a very good coordination between the staff, the patient, the machine, and of course, it's a close coordinated efforts which are required much more than in mechanical ventilation, which you need to consider when you put the patient on non-invasive ventilation. Thank you very much, Chairperson.